Hello friends, today we have Professor Di Renzo, who is the pioneer as far as the reproductive medicine is concerned. To his credit, he has lots of publications, lots of research work, and today we'll be able to know in more detail regarding the reproductive medicine, particularly for the luteal phase support as well as the preterm labor. Hello sir.
Oh, good day to everybody. Thank you very much, Dr. Nagori, to have me with you.
So, I would like to ask that in FET cycle, is there any significance of measuring the progesterone level where we are doing an embryo transfer in the freezing cycle?
Compared to the fresh cycle, I would say that there is not too much meaning to measure progesterone because, first the concentration of progesterone are not linked really to the action that the progesterone does in the endometrium, particularly the two major actions. One is to prepare the endometrium after the priming of estrogens to be implanted by the blastocyst, and the other is to prepare the mother locally and generally with the immunotolerance for not rejecting the blastocyst and the embryo. The usual amount of progesterone that is given is in between 800, but you can go up, or you can mix with the subcutaneous. I don't have too much experience with the combination, but I know that you have experience, and I think that you have a very good result also with the combination. Yes,
very good results with the subcutaneous injections, and that increases the blood level very fast. That is within 1 hour only you get a very good blood level. So either you can have, for this Japanese study, that you can give 1200 milligram of the vaginal progesterone, or you can have subcutaneous injections can be added if you are giving 800 milligram to the patient.
Exactly. We usually, at least in my center, use more the 800 to 1 gram to support the luteal phase in this fat cycle. The other phase is slightly different.
And second thing is the serum levels are quite low. Whenever we give vaginal progesterone, the concentration in the uterus is very high. It is almost 10 times high. And that's why there is no point in measuring the serum level of progesterone when you are using vaginal progesterone as a primary line of treatment.
Yes, for sure, yes. Good. That is quite clear, yes. But
now, in FET cycle, in India, what we see that commonly the people are prescribing dihydrogesterone along with the natural micronized progesterone. Now, the pharmacology says that the dihydrogesterone does not work when endogenous progesterone is absent. So there is no corpus luteum, and that is why the dihydrogesterone is not acting on the endometrium very much. What is your...
First, I would say that this kind of combination practically doesn't exist in Europe, except very few centers, but I don't understand why they do. In any case, the use of dihydrogesterone is a little bit a contrast to the action of progesterone, because one of the things that natural progesterone is doing, and only the natural bioidentical progesterone, so the micronized progesterone, is performing, is to synchronize the endometrium. So this means that when I start giving, the endometrium follows steps in preparation which are the same as in a normal natural cycle with the production endogenous of progesterone. If you give any other progestins, this doesn't happen, as well with the dihydrogesterone. So to give one substance which put in phase the endometrium, and another which is not capable to put in phase, tell me what is the sense. It's not for sure synergistic. Eventually, you contrast a little bit the action of progesterone, is counteracting. Instead of helping, is doing the contrary. So I don't see any issue really. I don't know what is your opinion.
Yes,
but
that is also one recent paper which has been published in Human Reproduction 2022.
Oh yes.
That even a 10 milligram which is given 3 times a day. And I'm surprised that one of the co-investigators is Professor Griswold, who has already done the work on dihydrogesterone, he himself says that 10 milligram 3 times a day does not give the in-phase
Yeah, because
endometrium.
it should be underlined that in that paper they were able to measure the dihydrogesterone metabolite in the blood,
Yes.
which is very complicated
Very
issue. You cannot take the progesterone levels when you give a dihydrogesterone.
Yes.
And of course, in normal patient, you don't know how you measure dihydrogesterone because it's very complicated. Measuring dihydrogesterone, they observe that is not enough and not capable to prepare the cycle appropriately. So, of course, they wish to find a way to do this, but this is a sign that they are still very far away from a real scientific evidence that dihydrogesterone does something.
So it should not be combined ideally along when you are
I
giving
think there is no biological plausibility to do that.
Now, a lot of papers are coming regarding the safety concerns of the dihydrogesterone, and a lot of countries don't have the dihydrogesterone in their country also. It has not been approved by the FDA of that particular country. So what is your opinion regarding the safety concerns of dihydrogesterone?
You know, when there is some safety concern concerning the drug, we have to be very cautious, not to be too much accusator, but at the same time not to be too much lighter, superficial. We are dealing with a patient which are taking this compound in a very sensitive time, which may affect the fetus. Now, not only there are papers which are telling that dihydrogesterone can be harmful for the patient, so for the woman. There are cases, for instance, of hepatic failure, cases of cardiomyopathy, which are being reported. Okay, they are anecdotal, but you know, all our discoveries about association between one drug which became teratogenic and the effect has been anecdotal at the beginning. There is not something that is so evident. And then epidemiologists they should prove. Now we have more little evidence that there is a safety concern which regard the use of dihydrogesterone, particularly in early phase of embryo development and cardiovascular congenital anomalies. So this means that this paper came out in 2017. There is another one soon later. And as far as I know, now at the Congress ESRE, there is a presentation of WHO data in which there is still confirming that there is a association between the use of dihydrogesterone, hypospadias, and cardiovascular anomalies. So we have to be very careful.
And also, many a times you may not find the malformations either in ultrasound, or sometimes you may find it after delivery.
You know, the
and many a times
cardiovascular malformations are the less diagnosed because they are so difficult. And sometimes you find after it's born, the mother forget completely what she took at the beginning. There is no association. Neonatologists don't recall what is the problem, and therefore sometimes gain unnoticed. You know, for this.
And now it has already been published in so many papers. So the patient may ask you. Why you had given me, I have got this complication, and you are responsible for that.
But in any case, at least in Europe, we are much more on the safe side for this.
So it's better not to use. Normally, people use different doses of progesterone, particularly when they are stimulating with the gonadotropin cycles, either in IVF or in an IUI cycle. Now, what should be the ideal dose of progesterone that should be given to the patient when you are stimulating the patient with gonadotropin, either for the fresh transfer or for the IUI cycles?
Now, the usual dose you start with is 600 milligrams a day, okay? Then now there is some trends, at least in some part of Europe, some of the very famous IVF center, to personalize this amount, measuring the concentration of the blood according to a cutoff which has been established by retrospective data. You know, so they say that, okay, if the cutoff is more than 10 nanograms, this means that your 600 milligrams is a good dosage. If it's less, go over. So add another 200 until you overcome this cutoff. This can be a useful way. This is valid for also intrauterine insemination, and remember, it's valid also on natural cycle in which we want to do luteal support in case of some difficulties, what we call unexplained infertility, but the patient is still not on, on the way to have IVF cycle or workup. So we can use few months supporting the luteal phase in this way, and you will be surprised because some studies have already shown that 35-40% of patients may remain pregnant just supporting very well luteal phase.
This is very important information because lot of unexplained infertility patients are on the waiting list of the IVF, and they do conceive when you give progesterone support, and they can conceive spontaneously.
But you agree with me that the support should be not just 200 milligrams, you have to give it at least 600 a day.
600 to 800 milligrams.
Yes, because this is a real support for the luteal phase.
Many a times we give 1200 milligram, particularly when your dosage of gonadotropin is very high, because that also suppresses endogenous LH. You use agonist and antagonist. That has also decreased the LH level. You have given, suppose the HCG as an LH surge, that also decreases the endogenous LH. So in all these circumstances, many a times the requirement is high.
But I know that instead of some groups that use the blood concentration progesterone, you rely also very much on your ultrasound capabilities.
Yes.
Tell us a little bit, because we you are an expert on that, about especially
level of progesterone by doing an ultrasound,
Doppler and so on. What you are your target?
We always see the endometrium and see whether even the pre-ovulatory rise of progesterone is present or not. And second, before giving HCG or before giving a trigger also, we know exactly what is the progesterone level by ultrasound also. And the endometrium, we can see what is the progesterone effect on the endometrium.
So this can be a very good information. If you don't have a patient which are available for checking concentration, blood and so on, I think that the possibility to check by ultrasound in your office is another valid solution, okay?
Okay. So it should be used in a proper amount.
Okay.
Now, people are using micronized progesterone vaginally. In India, a lot of people use intramuscular progesterone also. And now, fortunately, the subcutaneous progesterone has come. What we have found in our practice that the intramuscular injections are very painful. And second thing is, it has a lot of complications also, like sterile abscess. And now we have got an option available, and that is a subcutaneous injection, which is less painful. So either you have to increase the dose of the vaginal progesterone, or you have to supplement the subcutaneous injection instead of intramuscular injections. What is your
No, I agree with you. The intramuscular progesterone, we have to remember, historically was the only way to give in the past until macronization was introduced. Then, of course, people rely sometimes on intramuscular because, they want to obtain high concentration of progesterone in blood and so on. Unfortunately, in the last decade, there was this development to subcutaneous, which is, of course, much less painful, obtain very good concentration in the blood, and shown some study that the combination with vaginal progesterone increases the pregnancy rate and live birth rate.
Yes, particularly in a frozen cycle, there are some patients where you may find a progesterone level low, even though the progesterone levels are very high intrauterine, but they have added subcutaneous progesterone every day to this patient or on an alternate day, and they have found almost 25 to 28% increase in pregnancy rate. So subcutaneous projection can be added along with the vaginal progesterone.
Is a solution. Is a solution in some case. Yeah, for sure.
Now, many a times, I think one of the good use of subcutaneous injection is that when a patient of threatened abortion comes, there are a lot of patients who are afraid of putting a vaginal tablet because there is a bleeding. At that time also the subcutaneous injection can work very well. I personally feel that there is no harm in putting a vaginal tablet. You can put double the dose, rather you can increase the
I agree
dose.
with you. I agree with you.
Yes, so 400 mg
And
can be
also,
given.
what we can do is to give a couple of days of subcutaneous or eventually oral also, because the oral route is very much anxiolytic, so the patient feel a little bit less agitated because of the bleeding, and it stopped the bleeding very rapidly. So there is no real need. Anyhow, we may understand the patient are a little bit afraid sometimes with the bleeding. But in any case, either the vaginal is absorbed, in any case,
Yes,
even though there is a little bit of blood, or you add the subcutaneous, as you said.
Progesterone is a very good immunomodulator. There are a lot of people who say that the dihydrogesterone is an immunomodulator. But I think progesterone is far, far higher, better immunomodulator than the dihydrogesterone.
I tell you, the progesterone has a lot of roles during pregnancy, and some of them are adapted to the period of pregnancy. At the early beginning, what is most important to do is to modify the endometrium for what we call the secretory endometrium. In reality, is a modification, a series of modifications that favor the implantation. And secondly, of course, is to change completely the immunotolerance of the patient, of the woman, in order to accept these few cells, which are in any case foreign cells. Okay? In order to do this, progesterone binds to the lymphocyte and through a factor which is called PIBF, which has been recently discovered 20 years ago, modify the Th1 and Th2 level. Now, PIBF is dependent from the progesterone receptor, so progesterone is increasing tremendously PIBF. And many progestin doesn't do anything with PIBF. Dihydrogesterone seems to have a little action, but of course cannot be the same action as progesterone.
It's much quite higher action.
So increase, but not so much.
PIBF.
By the way, all the studies been done in vitro, remember. So we have to see in vivo what does, because this has not been demonstrated in any study in vivo, because it's difficult to measure, again, I told you, the amount of dihydrogesterone and also the changes in PIBF. Is complicated both, because PIBF is very difficult to measure. There is not a real assay that should be done by gas chromatography. It's a complicated assay and so on. So there are very few studies done mainly by an investigator in Hungary, which has shown, of course, some slightly difference, but for progesterone, for sure, is the agent which determines this modification.
Yes.
Is the property, is the intellectual property of progesterone. You understand what I mean? So the other can imitate, but don't arrive as the property of progesterone. Whatever you may think, progesterone is the real agent to make a difference.
Same is the story with 17-hydroxyprogesterone. Now all of us know
that is a very nice study. You know, that
safety and efficacy.
You know that 2 weeks ago, FDA has, but it's an American story mainly. Because I tell you, in Europe we never use 17-hydroxy because we didn't believe to this drug. By the way, you should know that 17-hydroxy was introduced many years ago. Then it was completely abandoned in Europe. Then it came back in the United States. And the United States was demonstrating that may have an action on the women with a history of preterm birth and to prevent subsequent the recurrence. Unfortunately, other study like Prolong, which has been done after 10 years of this, and make many center, multi-center, more than 80, 90 centers, and so on, didn't show any result. So the first data were challenged by this second study, and the Americans somehow try to save the problem in inventing, I should say, a meta-analysis, playing with statistics, using the data of natural progesterone, adding the 17-hydroxy and telling that the combined peers and the apples, as I say to many, is a very good taste, but are not the same fruit, and they show that there is the progestins, as we call, have a merit for prevention. Fortunately, a commission of FDA and expert, by the way, also the American College were very critical against this. But FDA, is an independent body, is not made only by obstetrician gynecologists. After a long evaluation, the very sad part of this story is that one, it has been calculated that the American health system pay more than $1 billion in buying drugs and giving drugs to these women without efficacy. Secondly, the only big side effect but consistent of 17-hydroxy, which is written even in informed consent, is the increased 3 times gestational diabetes. So the only result of all this is that there were much more gestational diabetes in the pregnant women who took this for, avoiding preterm birth. So I think it is very satisfying.
This is a good lesson for Indians also.
No, also not to pursue the use of drugs when there is not a good biological evidence of this.
At least in India, because it is used since so many years, and it's a good lesson now and a good
I think
point that it should not be used, and we should go for this micronized progesterone that is available to us. Recurrent implantation failure and recurrent pregnancy loss, the progesterone is very useful, and in majority of cases I think it works as more of an immunomodulator rather than the luteal phase defect. It does help for the luteal phase defect, but particularly in a recurrent implantation failure in the beginning of the RPL, rather than not giving the drug, diagnosing the patient for 2-3 abortions, it is always better to start progesterone to this patient as soon as there is one abortion.
Now almost all the international society, I know very well the Royal College, ASHR, because they are European, have endorsed the use of natural micronized progesterone at least 800 milligrams a day for prevention or recurrent pregnancy loss when a woman, a couple, let's say, experience at least 2 previous abortions. Or when a woman has treated the miscarriage, so is coming to any office with bleeding, with pain, with this, and she experienced already 1 pregnancy loss. This is what the evidence says. Of course, there is a point, and I think Dr. Nagori may agree, it's not easy now having this evidence that if a patient comes to your office with bleeding, you say, oh, my dear patient, the evidence say that at the moment you have only to eventually to go home a little and wait what happens, because the patient go out from the office, go in another office and ask to another doctor, why doesn't give me anything?
Absolutely right. We start
of course now you start in any case progesterone. Of course you don't have too much success, because we have to think that 50 to 60% of this bleeding may end in abortion, because there is a chromosomal abnormality of the fetus. You cannot do anything. You can do whatever progesterone you want, but the nature will expel the fetus in any case. But in the other 40%, which are not chromosomal, you can at least intervene in favoring the pregnancy. Okay, you agree with
this? Yes, definitely. If it is unexplained infertility or luteal phase defect, that will be prevented. You will be able to prevent.
But the evidence say this, and this a clear evidence nowadays, have been accepted by the major society in the world. So I think that there is nothing to dispute about this.
In a patients of preterm labor or the threatened abortions, we just discussed that in threatened abortion you can increase the dose of even vaginal progesterone, or if you want an immediate effect, you may give subcutaneous injections. Now, what about a preterm labor? What are your suggestions?
The preterm labor is by the way, the preterm labor recognize more or less the same risk factors as the miscarriage. So, because while pregnancy is a continuum, so if there is a risk that can be shortened at 16 weeks, can be shortened at 24. Probably it's the trigger is acting before, and in a second case is acting a little bit later. So one is called abortion, the other is called preterm birth. Apparently, progesterone works in both cases
Both
to
the
prevent,
cases,
as I
yes.
said. But the reason why we have to give a much more progesterone at the beginning to prevent miscarriage is because the action of progesterone is different from the action to prevent later
Yes.
the preterm birth.
That's
And we need less because the progesterone should be given vaginally because it has much more antiprostaglandin and anti-inflammatory and anti-bacterial status. I would recall you that there is a very interesting study who show that the colonization by Streptococcus B, which was one of the microorganisms linked with preterm birth, is decreased by 45% by
decreased by
vaginal progesterone.
Vaginal progesterone.
No other progestin is capable to do this.
Oh, that
only,
decreases the
only
anti-
yes, it decreases the colonization. So there is
Colonization.
less risk if
Less
you put
risk.
by vaginal route. You see, and it doesn't change the pH. So if the pH is acid, which is the good pH of vagina, it doesn't become or increase because of progesterone. Okay, so the pH remains acid and has the capability to decrease the Streptococcus B colonization.
So you normally give up to 16 weeks of pregnancy,
Yes,
milligram
and then
BD.
I go down to 200,
200
until
milligram.
36. This is the
So we
recipe.
start with the higher dose, particularly in RIF for recurrent pregnancy loss.
Yeah.
And the best thing is that we must start it from the luteal phase. People normally start once the pregnancy test is positive. But instead of that, if it is started from the luteal phase after the ovulation, then the pregnancy rates are much, much better.
Because we already lose 2 or 3 weeks
Right.
if we wait the pregnancy
Yes,
test, in which the modification that are usually done by progesterone may not come, and in order to modify the system is not so easy. So you can get much better result if you start early, and this is recommended also by ESRE and by the
Yes.
other society.
Now we are starting a progesterone, and now many a times because of the fear of the preterm labor, depending on the length of the cervix when it is less than 2.5 centimeter,
Yeah.
then you can have a preterm labor. And here in India, the cervical encerclage is very common. So is it enough, or we should give progesterone along with the cervical encerclage?
Well, let me say that you are the country of cervical the cerclage, because Shirokar was
Yes.
the famous
Yes, he established the-
oncologic surgeon who introduced this important operation. By the way, easy to perform, but so efficient, at least in the case. Now that we have the natural progesterone, we don't abuse, on brackets,
Yes.
of making too many circulage. For instance, Europe has decreased a lot the use of circulage. But when there is indication, let's say that Shirokar was writing in his paper cervical insufficiency, but it's not easy to determine what really is a
Yes.
cervical insufficiency. But let's say that if a patient has too late abortion, too early preterm birth, for sure there is something in the cervix that is not continent, okay? So the circulage can be an indication, okay?
Yes.
In this case, there is a merit to continue after the circulage
Yes.
to give progesterone, because it has been shown that prolong the pregnancy and avoid treated episode of treated preterm birth.
See, even if the cervix is 3 centimeter long, and if you do ultrasound,
Yeah,
if
can
you do
give-
elastography,
yes,
and if it is a soft cervix,
Yeah.
you must start
Yeah.
progesterone
Yeah.
to this patient,
I
and
think
that
it is
recovers the cervix from the softness.
Exactly.
So
yes.
that is to be given
Yeah.
to the patient.
Yeah, this is a very good way. Huh?
So thank you very much, sir. You have told us in detail how the micronized progesterone is to be used for luteal phase support, for recurrent implantation failure, for recurrent pregnancy loss, and for the episodes of preterm labor. The micronized progesterone works very well, and you have cleared all the doubts regarding the safety concerns of the other drugs which are available in the market.
Yeah,
Thank
no,
you
but
very much.
thank you, Dr. Nagori, because apparently you have my same ideas, and therefore it's
Yes,
very important
yes.
that the Indian community and the doctor and the obstetrician who care for women, or they are involved in assisted reproductive technology, follow opinion leader like Dr. Nagori, because he has the right idea. in this sense what to suggest and to do better for our women and for the success of the pregnancy.
Thank you.
Thank you.